Good morning, good everyone. Good morning and good afternoon, good evening, everyone. Welcome and thank you for joining us for this discussion. We want to have a look at the LAC trial, the laparoscopic approach to cervical cancer. It has been quite the talk in the last 5 years, and it's only important when we have the actual PI, Dr. Pedro Ramirez, to discuss it about the findings and what it means for us as people or the GYN oncologist who manage cervical cancer. So with us today is the highly esteemed Dr. Pedro Ramirez and Dr. Renee Pareja, who is also participating in the trial. And so without further ado, I'd like to invite Dr. Pedro Ramirez to take us through the LAC trial.
Excellent. Thank you very, very much, Anissa, for the invitation. And thank you, Kathleen, as well, for being present for this webinar. And I want to thank also the IGCS for providing the forum for this particular presentation. And then, of course, always a pleasure to share any webinar with my good friend and colleague, Dr. Renee Pareja from Medellin, Colombia. So we want to obviously take this opportunity to have those members of the participating audience to engage in discussion, and we want to make this a proactive discussion. So we're just going to give a brief overview of the details of the LAC trial, and then subsequently some of the updated results of the LAC trial that are soon to be submitted for publication. And then what has happened in terms of a practice pattern in the United States as it pertains to radical hysterectomy, and then just address some of the more controversial topics that have been recently published in the literature. So as many of you know and are aware, the LAC trial was published in 2018, New England Journal of Medicine, and this was a prospective randomized study evaluating open versus minimally invasive in patients with early cervical cancer. Subsequently to the findings of the LAC trial, which had shown a worse outcomes for minimally invasive radical hysterectomy, there were a number of publications that looked specifically at oncologic outcomes, and these are compiled in a meta-analysis and systematic review that was published by Roni Nitecki at MD Anderson. And over 9,000 patients basically were evaluated. And this was a study and a meta-analysis that looked also not only at the studies that have been published, but also it evaluated the quality of those studies through the Newcastle-Ottawa classification. And what the study found was that, again, consistent with a LAC trial, the risk of recurrence and death was worse with minimally invasive surgery, and the risk of all-cause mortality was worse with minimally invasive surgery. And then once again, reiterating that when evaluating oncologic outcomes in the setting of a meta-analysis and systematic review, minimally invasive radical hysterectomy was associated with a higher risk of recurrence and death compared to open surgery. So what has happened in the United States since the publication of the LAC trial in 2018? There were a number of studies that looked at the patterns of practice in the United States, and this is actually just a few months after the presentation of the LAC trial at the SGO in New Orleans in March. There was a significant decrease in the number of minimally invasive radical hysterectomies performed in the United States. Subsequently, and more recently, a national inpatient sample database of over 6,000 patients by Koji Matsuo and Jason Wright also showed that since the publication and the presentation of the LAC trial, there was a significant decrease in the number of minimally invasive radical hysterectomies in the United States. We subsequently presented the updated results of the LAC trial, meaning when patients were followed all the way to the end of the 4.5 years. And these are all eligible patients that were followed to the end of the 4.5 years. And as you can see, over 90% of patients were followed to 4.5 years after the completion of the LAC trial. We're in the process of putting the manuscript together to submit for publications. But what's important and to take away from this final analysis is that the results were very consistent. So the results again showed that there was 4 times higher recurrence with minimally invasive surgery. And again, as you can see here, a 4 times higher rate of recurrence with minimally invasive surgery. There was worse progression-free survival. There was worse disease-specific survival, worse rates of local and regional recurrence with a minimally invasive approach, and worse overall survival. So, in other words, not only was there a confirmation of worse disease-free interval, but also worse overall survival, therefore reaffirming that the minimally invasive approach was not ideal in the setting of early cervical cancer. So there were a number of questions that came up, and we did what is called an exploratory analysis. And basically this is looking back at the data in the LAC trial, but this is not points of design in the study. So therefore, this is what is called an exploratory analysis, which basically means from the data that you had, looking back at these questions, what were the results? But again, these were not in the design of the study. One of the questions that has come up is the issue of residual disease. And of course, in patients who have no residual disease, the number of events were very, very low. So as you can see here, there were no recurrences in open surgery. There were 2 recurrences in minimally invasive surgery in patients who had no residual disease in the surgical specimen. And then in the overall survival, there were no events of death in open or minimally invasive surgery. One of the points that has come up is the issue of tumor size. And we can discuss this later when we go through the questions that will arise from this discussion. But basically, the question is there a particular tumor size where minimally invasive surgery is potentially worse? And clearly, over 2 centimeters, there's a significantly worse recurrence rate in patients undergoing minimally invasive surgery, hazard ratio 4.25. In patients with tumor size less than 2 centimeters, again, there were no recurrences in the open surgery group. So then, therefore, one may not estimate whether minimally invasive surgery is worse. But by just looking at this Kaplan-Meier curve, then certainly one can see that at least in terms of recurrence events, there were much higher recurrence rates in the minimally invasive group. But statistically, we cannot attribute one being worse than the other because there were no events in the open arm. The other question, and we can definitely discuss this, and I would like to discuss this a little bit later, is the issue of cone. And this has come up with regards to if you have a cone, you do worse versus not having a cone. At least in the evaluation of the LAC trial results, patients who had no previous cone, the minimally invasive surgery had 6 times worse recurrence than the open surgery approach. And when looking at having had a previous cone, in other words, patients who had a previous cone, there was no difference in terms of the outcome, open versus minimally invasive. This is another point that was very important, is the rate of carcinomatosis, and it was over 20%, 24% rate of carcinomatosis in patients who had minimally invasive surgery versus those who had open surgery where there were no events. Now, this is the question of now beyond the LAC trial, what are some of the issues that have been discussed? And one of them, of course, is that the spillage of tumor. Can that be worse with minimally invasive surgery? And the vaginal protective maneuver, Christar Kohler published in the International Journal, a very nice article about the protective maneuver. And of course, it was a retrospective study potentially suggesting that if you do a protective maneuver, the outcomes by minimally invasive surgery may not be as concerning. This is another study, again, a retrospective study from multiple institutions in Europe. Many of you are familiar with the study. It's called the SUCOR study. That study also confirmed that minimally invasive surgery was worse than the open surgery approach. But one of the things that they looked at was the protective maneuver. And what they found was that in patients who had a vaginal protective maneuver by minimally invasive surgery, the outcomes were similar to the open approach. And again, we can discuss that during our question and answer session. The other question is, tumors less than 2 centimeters. There are a number of studies that have looked at this question. One of the first ones after the Lac trial was a study by multiple institutions in the United States and one in Canada, where they looked specifically at less than 2 centimeters. And they also found that minimally invasive radical hysterectomy, including those tumor size less than 2 centimeters, had inferior disease-free survival. This is another large study from China, again, looking at that same question, and they found worse disease-free survival for patients with tumors less than 2 centimeters. Subsequently, a large study here in the United States, over 2,000 patients, and they showed that patients who had minimally invasive surgery have worse overall survival than those that had open surgery, again, even in the less than 2 centimeters. So again, suggesting that less than 2 centimeters does not automatically provide a safe factor for proceeding with minimally invasive surgery. The other question that has come up is cervical conization. And there was a study called the Sucre cone study that evaluated patients who had a cone versus those who didn't. And it's very important, and again, I will highlight this in the discussion, is that whether a patient has a cone or hasn't had a cone, those studies are not being equated to it's okay to do minimally invasive surgery in cervical cancer if you do what is called a prophylactic cone. That is a complete misinterpretation of the data. So the data is showing that if you have a cone, you're going to do better than if you don't have a cone. That intuitively is expected because obviously patients who have a cone typically have microscopic disease versus those who don't have a cone. And this is the finding: prior cervical conization has significantly lower risk of relapse. Minimally invasive surgery without a cone had a higher chance of relapse. Same findings as the Lac trial. And prior conization and minimally invasive surgery had similar outcomes. But again, this was not a study that was comparing open versus minimally invasive. And again, it's a retrospective study. The present study should be regarded only as hypothesis generating. There was another study also looking at the same question, and the same findings were found. But again, there are different comparative groups, and I'll highlight that in our discussion as well. Lastly, the question of microscopic disease. There are many who say, well, in a patient who has a 1A1, in a patient who has had a cone and has no disease at the margins, why can't we do minimally invasive surgery? And there was one study from Dimitrios Natsioutis, 1,900 patients, that basically said laparoscopy or laparotomy in 1A1 patients actually makes no difference. And again, that's a large database study in a patient population, 1A1, that doesn't need a radical hysterectomy. So again, we can be discussing that further. And then lastly, obviously, since the Lac trial, we have had a number of guidelines that have changed to recommend the open surgical approach as the standard of care. And that is the standard of care. So minimally invasive surgery today in cervical cancer should only be performed in the setting of a clinical trial. Outside of the clinical trial, you are basically practicing medicine outside of the guidelines if you're doing minimally invasive surgery for cervical cancer. So conclusions from level 1 evidence: worse oncologic outcomes with minimally invasive surgery, similar outcomes pertaining to complications and quality of life. All the guidelines support open, minimally invasive surgery only in the setting of clinical trials. The vaginal protective maneuver hasn't been prospectively evaluated. There's no data on learning curve, no data on quality of life. Less than 2 centimeter tumors, minimally invasive surgery has shown worse outcomes than open surgery. And conization improves outcomes in patients with cone is not because of the cone, but rather because of the patient profile. In other words, people who have cones are lower risk patients. And for patients who have very microscopic small disease, minimally invasive surgery likely is okay, but there's no prospective data. The basic principle of clinical research, and I'm sorry, that picture is a lot bigger than I thought on the slide, but the basic principle of clinical research dictates that new standards of care and changes in patterns of practice should only be supported by well-designed, adequately powered, and well-conducted randomized trials. I'd like to leave you with this article in that for any who ask the question, well, why does a prospective study show something and some, not all, but some retrospective studies do not show the same findings? This is an article that we were invited by the Journal of Clinical Oncology to write about why does prospective data may potentially show something different than retrospective data. With that, I'd like to conclude by inviting everyone to join us in Seoul, Korea for IGCS 2023, November 5th through the 7th. We hope to see you all there. Thank you very much.
Thank you so much, Pedro, for that comprehensive review of literature and all that we've been going through. So it's important to understand that as much as we've had this large randomized trial done back in 2018, over the last 5 years, there's still a lot of controversy that is still being brought about, and different guidelines are still coming up. And so one thing I'd like you to tell us, Pedro, is when you were creating the LAC trial, when you're going through the process, what question exactly were you seeking to answer? What was the landscape like in 2018 for you to come up to set up this trial?
Back in 2008, which was when we started the LAC trial, we had data about endometrial cancer. And we had data from the GOG Lab 2 study and from the LACC trial in Australia that endometrial cancer minimally invasive surgery approach was safe. The concern with cervical cancer is that basically it is a very different type of cancer. Endometrial cancer is a small tumor, often microscopic, confined within the cavity and the protection of the uterus. So therefore, there is no tumor exposure. Our concern with cervical cancer is that you have an exophytic gross tumor undergoing manipulation under a minimally invasive approach with obviously a pneumoperitoneum, so high pressurized gas. And the concern was, is this non-inferior? So meaning, in other words, the laparoscopic approach, is it safe as compared to open surgery to doing this approach? So then that's why we did a prospective randomized trial to evaluate that question.
All right, thank you for that. And now there were so many centers that were included in the study, and Renee, your center was one of them. You were in South America, Colombia to be exact. So while most of the centers, if not all the centers, were upper middle income, were there some specific challenges that you faced in your center that were unique to you?
Thank you, Anissa, for the question. At that time, I was working in a third-level cancer center. And in third-level cancer centers in Mexico, Argentina, Brazil, Peru, and Colombia, there were trained people for doing laparoscopic radical hysterectomy. So we got a lot of patients and we got a lot of experience handling the disease by laparoscopy. That's the reason because we were invited to participate. But I have to clarify that there is no the real life in developing countries. It is not even the real life in Colombia, because in 2008 in Colombia, probably 2 or 3 hospitals were able to perform laparoscopic radical hysterectomy or laparoscopic advanced procedures. So most of the radical hysterectomies were done by laparotomy. And the same thing happened and happens in the real world, because, 80% of cervical cancer occurs in developing countries, 90% of deaths occurs in developing countries and low and middle income countries. So the real life of cervical cancer is laparotomy. The discussions about the approach, minimally invasive versus open, is an academical question among academical institutions in highly developed hospitals in North America, in Europe, in Asia, particularly Japan and Korea. But in the rest of the world, the radical hysterectomy has been done historically by laparotomy.
Thank you very much for that. And I'm glad that you brought up this element of surgical expertise. I know, Pedro, you were talking about the learning curve, that it has not been really explored. But when you were selecting the surgeons for this trial, I know it's been asked quite a bit that one of the requirements was that they should have had at least a minimum of 10 minimally invasive radical hysterectomy. So what guided your criteria for the selection of the surgeons who did the study? And for as a follow-up to that, what would you say? Right now, so many people, the whole world entirely is moving to laparoscopic, robotic surgeries. So who exactly should be doing this kind of surgery? Should it just be the GYN oncologists who are trained in MIS, or can an expert general gynecologist do this surgery just because they know the anatomy and they know how to do minimally invasive surgery? Your thoughts?
Yeah, I mean, first I would say that no one should be doing minimally invasive surgery for cervical cancer, regardless of their expertise, based on the data and based on the guidelines. So that should be very clear. There should not be exception tickets. In other words, I am a unique surgeon, or I am a special surgeon that I should be performing this procedure. Now, as it pertains to the learning curve, we in the LAC trial, we actually set up the LAC trial to make minimally invasive surgery look much better than open surgery. And what I mean by that is that we actually selected very expert surgeons like René, surgeons like Reitan Ribeiro, surgeons who really had great capacity in surgical skills. We obviously, we reviewed videos and we had data on any 10 patients. It should, and again, it should be reiterated. It wasn't your first 10 patients. It was on any 10 patients. So it wasn't like, oh, okay, well, now that I've done 10, now I'm considered an expert. So there could have been a lot of criticism of this study if it showed that minimally invasive surgery was better, because then easily, anyone could have claimed and said, of course it's better because you have outstanding surgeons doing it. But in fact, actually, it showed the opposite. Even with outstanding surgeons, the minimally invasive recurrence was worse. So then it is important to look at and evaluate that element of the scrutiny for the study. The other thing is also is that you hear, well, it should be an expert surgeon. I would love for anyone to give me an objective definition of what is an expert surgeon. I do not know of any surgeon in the world ever, anywhere, that walks into an operating room and says, I am at best mediocre. Every surgeon sees themselves as an expert surgeon. So all of this stuff about, an expert center and an expert surgeon, I would love to see the definition of that, because I don't know what that means. So certainly, obviously, in the setting of the LAC trial, we picked surgeons who had extensive experience in laparoscopy, who would demonstrate that qualified experience through a video evaluation.
That's particularly awesome, because I think that has been one of the conversations that have been around what they're just residents doing, the surgeries, what they're fellows, who exactly are the expert, who defines what an expert is. And so I think you've answered that quite well. And so I know, Pedro, you've talked about the TECH's systematic review, which was released in 2022, I think it was. But now, René, based on that review, it really supported the findings from the LAC trial. However, we have other systematic reviews, for example, COW in 2015, GITA in 2012, that are saying the opposite of the LAC trial, that there's no difference. What is your thought on this? Why do we have these two great systematic trials giving different options?
Well, thank you, Anissa. I have to remind you the pyramid of evidence. And in the pyramid of evidence, in the top is the randomized clinical trial, which is considered the standard of proving or denying a hypothesis. The systematic literature reviews published, there are some positive ones, there are another negative, Ronnie Niteki published, the Pedro mentioned before, with evaluating with Ottawa scale the quality of the studies, but also retrospective studies from Latin America, from Europe, SUCOR, have shown different results. And this is because the nature of the data you capture. In a randomized controlled trial, you have all the information collected with a predefined and specified goals. Gathering previous information and doing or writing retrospective papers is always information that have to be taken carefully because all this information is biased and there is the bias of the design. So you can find a study reproducing the same findings of Lac Trial, such as SUCOR, showing a worse behavior for minimal invasive, but you can find another study called Memory from the guys from Memorial Sloan Kettering, and this study shows that there's no difference and the performance is the same. But in that study, if you dissect this study, you can find that the exposure of the surgeons in that center is about 2 laparoscopic radical hysterectomies in a year. Is that enough for being an expert? I think no. I think there is a clear bias in the way we consider the literature. So retrospective literature is just hypothesis generator. Prospective evidence could be practice changing depending on the outcome.
Yeah, and
Thank you very much.
I think Renee put it, perfectly well. And I think it's also important to highlight is that when you're looking at a retrospective data, there is no element of balancing for confounding factors. What does that mean? When you're looking at retrospective data, you have open surgery patients who have bigger tumors, more radiation therapy, higher likelihood of lymph node metastases versus minimally invasive surgery, smaller tumors, less adjuvant treatment, less metastases. So of course, the minimally invasive surgery group is going to be better. So certainly, again, it's the confounding variables, the retrospective nature. When you say, well, it's a systematic review or it's a meta-analysis and it has like 1,000 patients. If you put together 1,000 patients from 25 studies that have all of these flaws, you're going to get the same result. You can go to 200 studies. You can go to 5,000 studies. If all those 5,000 studies still have the same flaw, it doesn't matter how many patients you have. It's the study design that needs to be evaluated. So when you have that, then if you have retrospective, not adjusting for confounders, small sample size, then you cannot use that as the same weight as a prospective randomized study. It's a simple math statistics 101.
I would like to add, I'll give you a clear example of a bias in retrospective literature. I'm going to ask about SUCOR conization. In SUCOR conization, you have patients with tumors 2 centimeters, 3 centimeters, and even 4 centimeters cervical cancer. What is the indications for a conization in a patient with a 4 centimeter cervical tumor? There's no indication. What is the flaw here? There is no information on the indication of the conizations. So there is a clear bias in the study. So the only way to demonstrate that a conization have a protective effect in cervical cancer by minimal invasive approach is doing a prospective randomized trial. Because if we base our decisions in retrospective trial, we don't really know what we are doing with our practice.
Exactly. And so we can't really compare apples and oranges in this kind of a situation. And so Pedro had mentioned about why endometrial cancer was seen as a safe surgery, a safe option for minimally invasive surgery. But now, Renee, could you tell me what is, and this might be a bit unfair because you're a GYN oncologist, but I just wonder, what is the difference between MIS done for prostate cancer, colorectal cancer, because we've not had big issues with this kind of surgeries in terms of poor oncological outcomes. So Renee, you can give us some thoughts, and then Pedro, you can go.
Yeah, I think there are several reasons. Pedro addressed some of them when talking about endometrial cancer. The tumor is confined inside the womb. Same for colon cancer, because you can close the tumor between the staples. But in cervical cancer, there is some exposure of exophytic tumors to manipulation with uterine manipulators. And sometimes it could be tumor cells can go to the abdominal cavity and to cause relapses. But there are more hypotheses, not only the uterine manipulator, what is blamed as the main reason for relapses, but the steep Trendelenburg position can be another one, or to perform first the lymph node dissection and do not extract those lymph nodes. So those lymph nodes possibly harboring metastatic disease can be left into the abdominal cavity for 2, 3, 4 hours, and the pneumoperitoneum can circulate those cells. Another reason is the possible magnification that laparoscopy can make in the radicality. So you can appreciate a huge parametrial take, but at the end is not too much. So unfortunately and fortunately, both the Lac trial was not designed to provide the reason of the outcome, but the outcome is what it is. So in order to prove the outcome, there should be another randomized trials trying to fix the problems that Lac trial could have.
And Pedro, do you want to add on to that?
Yeah, I mean, the only thing I would add is that, again, when looking at the questions of etiology, and many have proposed this as a weakness of the Lac trial, we always have to remember, anyone who has conducted prospective studies, or anyone who understands prospective studies, knows that you cannot ask a question of a prospective study after the results are out if that question was not in the initial design. So in other words, to say, well, you didn't tell us the reason. Well, the study was not designed to tell a reason as to why there was worse outcomes in MIS, because we didn't know that MIS was going to be a worse outcome. It's Dr. Schmaler is sitting next to you. She conducted a very important study, the CONSERVE trial. And it's like finding at the end of the CONSERVE trial that there was a higher propensity for thromboembolic events. And to say, oh, the CONSERVE trial was terrible because it didn't tell us the reason why patients get thromboembolic events. The study was not designed to find why patients got thromboembolic events. So again, it's something that gives us an opportunity to study things further, but it shouldn't be a criticism of the study for not giving you the reason for a question that you have after you know the results.
Absolutely. And so that actually brings us to a question by Khalid Al-Khalifa, and he's alluding to what we've been talking about. What do you think were the causes of these poor oncological outcomes? I know we've talked a little about the tumor size, but even if we're talking about tumor size, again, there's been different studies talking about whether it's related and whether it's not. Colonization, again, it's been a problem, and also about carbon dioxide pneumoperitoneum. So what are your thoughts on this? What could you explain for this?
Most likely, I think that the most obvious reason is tumor spillage and contamination, because it seems that it's blatantly obvious that in larger tumors, the outcomes are worse. Blatantly obvious. I mean, even in some of the retrospective studies, that when you break it down by less than 2 or more than 2, the more than 2 is always worse outcomes with minimally invasive surgery. So most likely that seems to be the higher likely reason, but we don't know. That it hasn't been studied prospectively.
Renee, do you want to add on to that?
No, I explained it before.
Absolutely. And so back to you, Renee. When we had the LAC trial, we had only about 15.6% who underwent robotic surgery. Now, knowing that the robotic technology has really kind of improved dexterity and it's the brand new toy in the recent advances in medicine, what are your thoughts about this, MIS versus conventional? As much as you're saying we're not doing MIS for cervical cancer, do you think this had a big impact on the LAC trial?
Anissa, I love your question. You said that robotic technology has a huge impact in medicine, not in medicine, in commerce, in markets, but not in medicine. You cannot find in the literature a single study comparing conventional laparoscopy, that is so-called straight laparoscopy right now, with robotic surgery showing better outcomes. All of the studies shown better outcomes regarding postoperative variables such as pain, bleeding, surgical time, admission times, but there's no difference between robotics and laparoscopy because are the same. A robot is a tool for performing minimally invasive surgery, but the robot doesn't make any surgeon better. A surgeon has to know the anatomy, how to treat the tissues, how to dissect, how to find the spaces, how to operate the patients in the best logical way. The robot doesn't provide none of that. The robot is just a tool for those that needs a robot. And who needs a robot? I don't know. Some people feel better operating in a seat or operating in 3D, but terms such as dexterity or many degrees of freedom, this is just a commercial strategy in order to convince the doctors, the hospitals, and the patients that they had to be operated by a robot. But Crystal Kohler, Eric LeBlanc, Denis Curlew, Pedro Ramirez, Raytan Ribeiro have made very important contributions to science using strike stick laparoscopy. So please don't trust that the robot is the answer to this question. The robot is just a tool. And if the robot deserves a Nobel Prize, it's the Nobel Prize of marketing, but not in medicine. Thank you, Vanessa.
Thanks for that. I'm sure the people doing the ROC and the RAC trials might not like you very much right now. So Pedro,
not my problem.
You speak the truth. So Pedro, tell me something though. Randomization was suspended because of the imbalance in depth. And initially your study power was set at 87%, but after the randomization was suspended, it dropped down by about 3 points. How could you say that this impacted statistically to the results of the study?
Certainly for statistical questions, I'm definitely not a statistical expert. I'm not aware that there is any information regarding the 3-point drop of the power of the study. We had 3 senior statisticians who had previously published in journals like Lancet and New England Journal of Medicine, and all of the statistical questions were from the New England Journal of Medicine were obviously answered appropriately. So there was not any issue at all in question of the statistical power of the study.
Very good. Because I think it's been said that because the study was closed prematurely, it might have impacted on the kind of interpretation from the results, which, as you've clearly said, not really.
Actually, that I can answer. The statistical power of the study, and when the study was closed, it was deemed that in fact we can already report on the results of the primary objective of the study, which was disease-free survival, because there was already such a disbalance in terms of the recurrent of events that we already had answered the question of the trial, and that's why we felt that certainly it was very valid to answer the question. So it wasn't that at the time of study closure we didn't have enough events. And I think, certainly that would have been a remaining question if at the time that we closed the study, if it had been a separate reason, say a non-oncologic reason for closing the study, say complications or something like that, where there had not been enough events of oncologic outcome, then one could argue and say, oh, look, because you closed the study, we don't know the answer. But in fact, actually, it was already answered because there were already enough events to already answer that question. And again, I mean, the other thing also is that, frequently, frankly, the question of like, oh, why did you close the study? That question often is asked by anyone who doesn't understand the principle of prospective randomized trial, somebody who doesn't understand the principle of the Data Safety Monitoring Committee. If you put a study for 1,000 patients and at 500, you're being told 5 times higher likelihood of death in drug A versus drug B, there is no ethical possibility of continuing that study. You cannot continue that study. That's why there's a Data Safety Monitoring Committee that protects patients from continuing to be exposed to a worse outcome. So you can't just say, well, let's just keep going to see what happens. No, I mean, you already are seeing 5 times greater likelihood of death with drug A versus drug B. Why would you want to keep giving drug A to patients?
Absolutely. And so I'm going to twist this a little bit. And I know the LAC trial was not powered to look at early cervical cancer. And I love that I have Kathleen Schmeller next to me because we're going to go into the CONSERVE trial a little bit. And I have a question from Jivansa Kochevelli from Georgia. And she asked, there have been these interesting findings where the non-inferiority of simple hysterectomy for early stage low-risk cervical cancer. So for these patients who we are advocating for simple hysterectomies, should they get minimally invasive surgery? Kathleen, could you maybe start with that?
Sure. So first, thank you so much for letting me join at the last minute. Anissa and I are actually in Mozambique, so it's great for us to be together as part of an IGCS program. One, I have to say I was a little bit surprised when I heard the topic for tonight because I don't know how many times we can keep talking about this. I mean, in what other specialty can a randomized phase 3 study stopped by a Data Safety Monitoring Board published in the New England Journal of Medicine with extensive peer review still be under question? It's truly, truly amazing to me, the psychology of this. But that being said, I'm very happy to join and talk about CONSERVE as well. I think the very, very important thing that everyone needs to remember is that neither CONSERVE nor SHAPE were designed to answer this question. You can try to twist the data in many, many ways, but our studies were not designed to look at MIS versus open surgery. In the CONSERVE study, the large majority, over 95% of our patients underwent minimally invasive surgery. And it's really amazing to think about that, but it was because we just assumed it was better or as good without the randomized data. And it wasn't until the very, very end of the CONSERVE study that the LAC data became available. And of course, we were all surprised by the results. So I think that the difference with the CONSERVE trial is that everyone got a LEAP or cone with negative margins before they underwent their simple hysterectomy. So all tumor was by definition removed prior to undergoing the surgery. So we're not sure if that, is the impact. What I will say is that when we were doing our study, we had an arm where patients who had undergone an inadvertent simple hysterectomy. So these were patients who had a simple hysterectomy done without anyone realizing they had cancer. And then the final pathology showed cancer. We had 16 of those patients, and 2 of them recurred, and it was very concerning. And actually, the DSMB stopped our study because we needed to look into that, because it was 16% of our patients, and we actually excluded that arm from the study. We never understood why. And I will never forget talking to Rob Coleman, who's obviously a friend and mentor to many of us and one of the smartest people we know. And he said, Kathleen, there's something about these patients and having a hysterectomy minimally invasive when the tumor is still intact. But anyway, we don't know why those patients recurred, but shortly thereafter, the LAC data became available. And it's a good question. But again, I just want to be clear, the CONSERVE study was not designed to answer that minimally invasive question.
And so if I can just add a question to that, when you mentioned the SHAPE trial as well, and for CONSERVE, you excluded LVSI patients, but for the SHAPE trial, they included LVSI patients. So, but for both, I think the node involvement was about 5%, if not less. But now, where would you categorize LVSI? Is it as part of an early low risk or early high risk?
Yeah, I think it's unclear. I mean, what we know is, I think that the risk of LVSI was thought to be associated with lymph node involvement. In our very, very conservative group of patients, they were LVSI negative, and we still had a 5% positive node rate. So I think that the only conclusions I can draw is that LVSI positive or negative, these patients need a lymph node assessment. But Renee and Pedro may have more insight onto the question of LVSI.
Pedro, Renee?
Yeah, I mean, I just wanted to add, because obviously Kathleen described it very, very well. When the audience reads papers on whether you can perform a laparoscopic approach if you're doing a simple hysterectomy, just because 94 patients on CONSERVE had laparoscopy and the recurrence rates were low, or just because in SHAPE the majority of patients had laparoscopy or robotic surgery, remember, again, and Kathleen said it extremely well, and it should be re-emphasized, CONSERVE was not a study looking at MIS versus open. The SHAPE trial was not a study looking at MIS versus open. And then one could argue and say, yeah, but so what? I mean, those are the findings. And that's we should take that as like also another great finding. The issue is that when you're looking at a comparison of 2 interventions, statistically, one of the first things that the statistician will ask you is, what is the rate of events of your point of interest? Rates of events of your point of interest. So they designed the study based on the frequency of that rate. Does this happen a lot? Or does this happen very, very infrequently? And then they tell you, in order to answer that question, you need not 631 patients, but you need 3,000 patients. And the overwhelming majority of people who assume just because you see this finding in a small study, that means there's nothing there. So a lot of people will say like, oh, look, in 112 patients, open versus MIS in that group, there was no difference. There's not enough events to see a difference. So therefore, that's why a statistician will tell you, to answer that question, you need 2,000 patients. To answer that question, you need 1,200 patients, because how often is this happening? So, certainly, if you're looking at a question of intervention A versus intervention B on nausea in chemotherapy patients, most likely you're going to need a small number of patients. But if you're looking at a question of recurrences in a population where the recurrence rate is already 0.5% or 1%, as it is in a patient with a 1A2 or a 1A1, then you need a lot of patients.
I would like to add to Peter's thoughts that LVSI has been always considered a high risk, but there is not a single paper showing this prospectively. the only paper published needed to add another variables to LBSI, such as tumor size or deep stromal infiltration, that was Cedric's trial. Because LBSI is a marker in locally advanced stages of bad oncological behavior, but it's not clear the role of LBSI in those very early, low risk, early stage cervical cancer. So in the CONSERVE trial, we have 5% of women with nodal involvement even having negative LBSI. And that's the rate of nodal involvement despite LBSI, 5%. Additionally, there is a very few relapses in the SHAPE trial. And in the SHAPE trial, LBSI was admitted because as single risk factor, LBSI has never been tested as a prognostic factor. So I would like to be very clear on that. When I finished my training 20 years ago or more, LBSI was an indication for adjuvant therapy. So we finished irradiating 50% of patients, 60% of patients. So LBSI have to be taken carefully. We need to wait the results of GOG 278 from Alcovens, because Alcovens have a similar design of CONSERVE, but with positive LBSI patients. This is my first consideration. And the second one is, I would like to remind that LAC Trial demonstrated a worse oncological outcome without any difference in complications and without any difference in quality of light. No difference in quality of life. What's the obstination on asking about still doing minimal invasive procedures if there is prospective randomized evidence with no difference in quality of life? Is surgeons' comfort? Is surgeons' view? I'm not sure about it. But when we stopped to perform laparoscopic radical hysterectomies in June 2017, nothing happened with my life. Nothing happened with my patients. We just shift to do open rad hist as we learned when I was trained, and nothing happened. So I mention this because I'm interested in the external validity of ROC and RAC trials. If ROC and RAC trials are positive studies, they will show that if you have a robot, you can use it, because both are non-inferiority trial. So if you have a robot, you can use it for operating a patient with an operable cervical cancer. And this is very, very far from the real life of cervical cancer. Remember, 80% of cases, low and middle income countries, 90% of deaths, low and middle income countries. Having a robot is not a concern. It's a concern of rich countries. Thanks.
And I always wonder if, because most of the countries, especially in the Nordic European countries, they're moving to MIS. And so is open surgery becoming a lost art that people are not even able to do open radical hysterectomies anymore? But I think, Renee, you've explained it so well.
Anissa, open cholecystectomy is a dead technique. And what happened if a surgical technique disappeared? Nothing happened. It is replaced by that should be replaced. That's it.
Absolutely. And talking about nodes, the ESGO-ESTRO ESP guidelines, they talked about doing frozen section on sentinel lymph nodes and then doing full pelvic lymphadenectomy. I would love to hear your thoughts. And also, Jivansa again also asked, what exactly is the safety of doing this for these patients?
This is not a lab-related issue, Anissa. What happened?
I had to bring it up because I know what you guys want to say.
Pedro, please.
No, this is a topic that Renee is very passionate about. So I concede the floor for the next 40 minutes to Renee.
Okay. We recorded.
Let me go write that paper while Renee answers that question.
we sent a letter and we recorded a podcast with Pedro because the European guys stressed the need of having negative nodes in order to proceed with radical hist, because we have the knowledge when we were trained that combining treatments could be hazardous or could be harmful for the patients. But this could be not true right now when we are using modern radiation techniques. So they insist in having negative nodes. So they perform a sentinel node detection. If the node is positive, they abandon the surgery according to APRAC's study findings. But if the nodes are negative with a very high sensitivity, some information will appear soon about this. Instead of being negative, they perform the pelvic lymph node dissections. My question is, why are they asking for sentinel node detection if at the end we'll perform a pelvic lymph node dissection? Because they don't have resources. So, but there's no rationale for doing this in real life in low and middle income countries. And since 2010, maybe, Pedro, I don't remember, the 2010, 2012, Al Covens, Pedro Escobar, MD Anderson, Memorial Sloan Kettering, most of the academic centers in the United States abandoned definitively the comprehensive pelvic lymphadenectomy when bilateral lymph node detection is negative, because it is enough. And there is a lot of publications, retrospective, most of them, demonstrating that there is no risk. The sensitivity is too high. So the reason is that the Europeans, I think, have to be sure that they will not perform over-treatment by making an over-treatment. So detecting sentinel node detection plus lymphadenectomy. It is a paradox here.
Absolutely. And I'd love for us to continue, but I see we're almost at the top of the hour. So in the room, I still have Mila. We have Mila Salcido joining us. I hope you can see her. And I have a lot of fellows from the rest, from IGCS, from the rest of Africa, most of Africa. We have Nigeria, Uganda, Liberia, Ethiopia, Kenya. And I'd like to ask if there's any burning question. Anything?
Just to say thank you, Pedro and René.
Yeah, it's great to see you all. I'm so jealous that we're not there.
You should be here, definitely.
And I see those cups are getting empty, so time to go refill them.
Our glasses are running that dry, but our minds are so full of all the knowledge that you've gotten to share. I truly appreciate you guys taking the time to come and talk to us about this topic. And so 30 seconds each, final thoughts.
René, you want to go first?
If we do science, we have to trust in science. If we have prospective, randomized, high quality information for changing a practice, we should change a practice. Please don't keep thinking about doing minimal invasive surgery when it's clearly contraindicated. That's my final thought.
Yeah, and I just want to, by thanking you and the entire team there for your efforts to continue to convey the message of science and evidence-based throughout the world, not just in first world countries, but certainly it is an honor and absolutely a priority for us to support you in this task. And we look forward to an invitation as well, so we can be there one day.
So, yes, absolutely.
I want the last 30 seconds. Just a reminder, cervical cancer is a completely preventable disease. We're so honored to have all the IGCS local supervisors and fellows here with us in Mozambique to attend Mila's course, to learn about colposcopy, LEAP, and HPV vaccination. So I really hope that together one day we'll no longer need LAC trials or conserve trials or all the things that Renee, Pedro, and I have spent our careers working on. But instead that we can completely prevent the disease. But in the meantime, I totally agree with Renee, trust science. I mean, really, I can't believe we're still talking about this, but I'm glad that you could both join us so that we continue to get the message out.
All right, so thank you so much, gentlemen, for joining, and for the audience who stayed with us for the last 1 hour. We really appreciate your presence, and Ashley and IGCS for putting this together as well. And we'd still like to extend an invitation to our annual IGCS conference in Seoul, November 5 to 7. Yes, so please join us. And we'll talk some more about this. I'm sure this conversation will still keep going on and on. So thank you so much. All right. Have a lovely day.
Bye-bye. Thank you.